Hi, I'm Gianna Boveri, and today I'm going to be teaching you about the health belief model. So, the model was created in the 1950s by sociologists who were wondering why individuals in neighborhoods that had been sent in with tuberculosis testing, why they weren't taking advantage of that, even though it was accessible to them. So, they created this model based on the cognitive theory, which says that mental processes inform behavior. So now we're going to talk about the six main constructs of the model, and I'm going to use an example through line throughout to help explain what each of these constructs mean. So the individual that we'll be comparing these things to is a college female on birth control who chooses not to use condoms when having casual sex. So the first construct is perceived benefit, and these are deemed advantages. So does the individual think that this behavior will help them? So for example, with a college female who is on birth control and who chooses not to use condoms for casual sex, using condoms being the health behavior we want to see, they might think that doing this might not serve them in a certain way. So maybe their partner might not like it. Perceived barrier, obstacles that would impede this health behavior. So what obstacles might prevent someone from doing this? So in our example of the college female who's on birth control, not using condoms, maybe not access to proper health education, not access to condoms, or maybe the stigma around it in their community. Next up is cues to action. So these are triggers, circumstances, or stimuli that would incite a health behavior. So the cues are what might trigger the behavior to happen. So this might look like health interventions on campus and sex education fairs, or maybe a culture shift in their friend group promoting using barrier methods for contraception. The next is perceived severity. So the question that we ask for this is, do they believe that the consequences of not performing this health behavior are serious? So how harmful someone believes a disease or condition is and the potential harm if left untreated. So this could be this individual female from college believing that getting an STD is really easy to get rid of, it's not that bad, or even getting pregnant, it is easy to take care of if that's the option that they choose. Next is perceived susceptibility. So this is an individual's subjective assessment of their risk of developing a health problem, the belief of how likely they are to develop an ailment or a specific health problem. So does this person think that they're at risk? So something that might impact this is maybe no one around them has gotten an STI, or they have trusted family members who talk about having casual sex without condoms and they've never gotten sick. And the last one we're going to talk about is self-efficacy. So do they feel confident in doing the behavior? So how confident one feels in their ability to practice a health behavior. So have they been taught properly about condoms? Have they had the opportunity to practice using one before? Do they feel like they can do this? Do they feel like they can have that conversation with their partner? So I think that might come down to education in this scenario. So with any model or theory, there's limitations and strengths. So first we're going to talk about the strengths of the model. So it's flexible and adaptable, allowing modification to suit specific individuals, groups, and cases. So it can be customized to explore behaviors in particular groups, making it useful in targeted health interventions and education. The model provides a framework to predict and explain health behaviors, and it helps us understand why individuals choose to engage or avoid certain actions related to their health. So on to the limitations. The constructs are extremely useful and informative, but there's not a lot of research to back up the relationships between them, and it's not consistently supported by research. Key components like cues to action and self-efficacy require further research, and though frequently used as a modifier, the perceived threat is used, but it's not officially part of the model. And last limitation would be it doesn't fully address environmental or structural influences on behavior. So while modifying factors are acknowledged, they're not among the six primary constructs and then are often underemphasized in application. So I think that the health belief model is an interesting tool to examine the reasons why someone may or may not choose to practice a health behavior. I've been thinking about individuals who may have had little to no success in obtaining a diagnosis or have spent endless rounds in the diagnostic cycle, who choose to disengage entirely from that cycle. So not going to doctor's appointments, not seeking a new diagnosis, etc. So for example, women with chronic pelvic pain. I wonder how their health belief scores would differ before entering the diagnostic cycle for the first time and then after they choose to disengage. A research study on this topic by McGowan et al. Tells us that women who exit these cycles choose to disengage because of medical gaslighting and insensitive delivery of negative exploratory laparoscopy results from a provider. So perhaps these interactions disrupt the patient's beliefs, but if the system has repeatedly failed them, what would need to happen to see success other than changing the health beliefs of patients? Just something to think about. Thank you.